home and in community. Now, home might not be the house you raised your kids in, but the idea that we're trying to keep people out of the healthcare system if they don't need to be there, or to bring the healthcare system to them if they need it, requires a different set of providers operating in different ways, and it's not just about physicians making house calls. So I think expanding the role of nurse practitioners is one of the ways we get to a broader, more competent workforce, and one that's not just locked up in the bricks and mortar of clinical offices and hospitals. I think the other recommendation that was super, super important from the commission, and also a little tough around the edges, is that we need to get serious about what it takes to help people thrive at home. And the fact that the system we have today is both, and I'll just say it, unethical and dishonest, and serves older people very poorly. So what do I mean by that? Well, the reality is older people often just need a little bit of help at home. Not big, complicated things. It may be as simple as helping with taking medications, or a personal care need, or skin care needs. Today, so you take an older person home, and a nice nurse will sit down with you at discharge and take this form that's written like 8-point font and write down all these little things you need to do, like you need to change the dressing 3 times, and then you need to flush this and give this IM medication, and it's your responsibility to call the surgeon and make an appointment within 7 days, whether or not that surgeon will actually have an appointment in 7 days. You're just sort of left with this sort of sheet of instructions, and there is some training in the hospital, and then it's kind of via con Dios, off you go. I hope that works for you. That is mortally unfair to those caregivers. That there is no oversight when that older person gets home. Those family members, whether it's a spouse or a child, are left to try to figure it out and put those pieces together. And they're often being trained when they're at the kind of the edge of their patience and skills and rest and tiredness. They've been looking after or worrying about a loved one who's been in a hospital for several days, for example. That's really, really not okay. And for lots of older adults, when they run out of resources or their family wants to help them, but maybe they don't quite qualify for Medi-Cal yet, families will go hunting for help, and they'll go hunting for help on places like Craigslist. So if anybody thinks there's any consumer protection, any level of oversight or training for folks you just sort of find in the ether to come look after your mom, dad, brother, sister, church member, fill in the blank, it's just simply not true. So the other major recommendation is that we need to get serious about what a universal home care worker could look like, because we have all these funny little titles that are ever so slightly different around the edges, and slightly different laws that create slightly different carve-outs for different kinds of folks who help in the home. And I think the commission makes a pretty audacious recommendation that we ought to clear that up, and we ought to get serious about thinking about what it means to provide a little bit of help in the home. And that happens in a couple of ways. So one is we think about a basic level of service, simple things. That's probably easy enough. Those are sort of family members and friends. Maybe that doesn't take a lot of help, but there's the opportunity to get them some education if they want it. There's sort of a next level, sort of an intermediate level of worker who could provide a more robust set of skills or services independently, and they would be formally trained in those skills. And that finally there's a higher level of worker who would have some additional training, maybe some level of recognition for that training, who would actually be partnering with nurses so that they're part of a larger care team to help that person thrive in community. Now that takes a little bit of changing in all our mindsets. So what is it? How do we sort of simplify these kinds of healthcare workers? How do we help see nursing? So as a physician, I feel really strongly that we don't do enough to recognize all the roles that nurses play today, and frankly, all the roles that they should play tomorrow, but for guild behaviors that prevent the recognition of those opportunities. This report lays out some really important, I think, initial concepts, which if we want older Californians to thrive, if we all want to thrive, need to be seriously looked at and implemented. So I appreciate the opportunity to chat with you today.
All right. I get to bat cleanup here. I'm Joanne Spetz. I'm at University of California, San Francisco, and I worked with the team of people that assessed the impact or the potential impact of these recommendations if they were to be implemented for the state of California. So, in essence, I'm here to share why we think there are reasonable numbers of workers that we can add to the workforce over the next 10 years, and why this is achievable and what benefit this will have for our state. And that benefit is not just numbers of workers and access to care. Those are also financial benefits. There's a return on investment. I'm a card-carrying economist, so that was very important to our assessment of this because we're talking about investing a lot of resources, and we want to make sure that these are well-spent investments. So to do this, we worked with Health Management Associates, and we analyzed the recommendations in detail. We reviewed all the numbers in them very carefully, and we also looked at the literature, both peer-reviewed and reports that have been published and so on, to take a look at what the impacts would be of having an adequate health workforce supply in behavioral health, in aging, in primary care. We also looked for research on the value of investing and that return on investment component of it. So in other words, when we have adequate access in behavioral health, in primary care, and for our aging populations and home care services, and they are supported by community health workers and peer providers, will we actually save money? So Dr. Flores referred to the collective set of recommendations leading to over 47,000 new healthcare workers in California, and those would be across many occupations: physicians, nurse practitioners, home care workers, psychiatrists, technicians, therapists, because we know that the need for well-prepared, diverse health workers cuts across the entire healthcare system. So those estimates were not limited to any particular profession. So I want to highlight the impact of those recommendations for ensuring an adequate workforce to meet the behavioral health care needs of our state's residents. The proposed expansions of psychiatric residency programs that were among the recommendations, one of the prioritized top 10, would add 2,202, don't forget those extra two, new psychiatrists to our workforce over 10 years. And those recommendations were designed to come up with that number, 2,202 in California. This would fill 75% of the shortage of psychiatrists that Dr. Janet Kaufman and I projected before the commission's work began. So that 75% would be filled with that expansion in psychiatric residencies right there. In addition, the commission recommended expansions of nurse practitioner education in general, with a particular target of expanding programs that are in the regions of California that are the most underserved, like the Central Valley and the Inland Empire and the northern Sacramento Valley. That would add psychiatric mental health nurse practitioners, because that's a track of specialization that many NPs choose to follow. And in addition, the commission recommended the creation of psych mental health NP programs for already licensed nurse practitioners so that they could either pivot fully towards doing behavioral health care services, or they would be able to add greater behavioral health skills to the primary care work that they're already doing. So these kinds of postmasters additional training and certification opportunities would really help to expand our supply. And when you add those recommendations together with the psychiatric residency recommendation, now you filled the gap. 100% of the gap that Dr. Kaufman and I estimated existed when we did a study a couple years ago before the commission. Now the commission's recommendations could fill that if they're fully implemented, which is pretty incredible when you think about that. If we add to that the peer provider recommendations, which provide this additional level of support that we've found in a whole variety of national and state research studies to really help people who have behavioral health needs, have somebody there who can be with them on a daily basis, who can coach them, who can say, I have walked this walk with you and I know you can do it. That is incredibly powerful. And when you have that partnership of the peer provider and the psychologists and the other providers that are in those 27 recommendations but not in the top 10, and then you add the psychiatrists and the psych mental health NPs, that's what we need to be doing for our older populations, for our younger populations, for everybody in California in order to fulfill the huge gap that exists right now in behavioral health care. Now, it's fair for you to wonder again, all of this is worth the money. 2,202 psychiatric residents is not a cheap proposition. Just that in the report, there's an estimate of the cost of that. The NP programs all have costs associated with them. You know, it's kind of sticker shock, right? A small share of health spending in California, but it's not an insubstantial amount of money. So I'm not going to bore you with all the details, but we looked really closely at the evidence of why this kind of an adequate workforce will save money. A few examples are that investments in our home care workforce enable people who have needs, who have some disabilities, to stay in their homes rather than be in a nursing home. Being in your own home instead of a nursing home is a heck of a lot less expensive. Whether that is the home you raised your own children in, or whether it is an assisted living facility where you're living in a community that is much more home-like, being out of a nursing home saves money, end of story. So if we can create workforce changes that ensure that people can stay in their homes, that is going to save money for our Medicaid program. It's also going to save money for family caregivers who are giving up hours at work, who are giving up promotions, who are giving up their own human capital in order to care for family members. And it's going to help other family members, spouses, and so on, reduce their own stress and reduce their own needs, which are all the sorts of things that drive people into institutional care when they don't necessarily need it. These small investments that Dr. Chernof mentioned can have a huge return on investment. We know from the research that community health workers, promotores, and peer providers are associated with cost savings when they're able to help their clients improve their own health in the field. They improve health literacy. They help people navigate our very complex healthcare system, and they help people make empowered decisions about their own care. And those things are all cost saving based on the research. Adequate behavioral health treatment, based on several different studies, has been shown to reduce overall physical health care costs by 20 to 30%. Because, you know, it turns out that your head is connected to your body. So when you have behavioral health care needs, that often also affects your physical health care seeking. Your ability to adequately take your diabetes medications is affected by how your entire life is going. And so these are whole body, whole wellness needs that need to be addressed. And it turns out when you address those, you save money because people don't show up in the emergency department. They don't feel as stressed. They don't have exacerbations of other physical conditions because these things are all very intertwined. So the research is 20 to 30% savings in healthcare costs overall for people who are receiving adequate behavioral health treatment. There is one study that we cited in the impact reports that treatment of depression alone is associated with a benefit to cost ratio of 5.3 to 1, which means that for every dollar we invest in depression care, we in our economy get more than $5 back in reduced healthcare spending, but also greater ability for the person suffering from depression to work, to support themselves, to support their families, for their family members to work and not be worried about their family member, and so on. So that $1 investment in that adequate care gives us $5 back in our economy. It's a no-brainer. These are just a few examples, and to be honest, we really couldn't add everything up very well because in some cases the research isn't that great, and in other cases the research was so wide-ranging it was hard to bring it all together and come up with a bottom line of cost savings. But just for the recommendation that nurse practitioners get full practice autonomy and don't have to be in collaborative arrangements with physicians, we came up with over $2 billion in savings by 2028 due to fewer emergency department visits and fewer avoidable hospitalizations. And that's not even counting the behavioral health benefits associated with that full practice autonomy. We know that that autonomy would also greater enable behavioral health services and substance use treatment services. And so just right there, that one recommendation, that one little recommendation of the 10 would nearly recoup the $3 billion investment recommended by the commission. If we add up all the other pieces, we more than make up for this investment. And that's where we came in with the impact statement and why this is so important, not only for the health of Californians, but also for the finances of California.
Well, thank you, Dr. Spetz, and please join me in thanking the entire panel for wonderful presentations. We have time for a few questions. What we would like to do is to invite you to come up to the microphone here in the middle. Just it'll be easier for us to track who has questions. There are index cards on your table as well, and if you'd like to write a question there or comments about the report, we'd welcome that. As you come up to ask a question, please identify yourself, and if you are representing an organization, and try to be brief because we do want to have a good conversation. So thank you.
Hi, thank you for your leadership and for your presentation today. My name is Katie Jordan. I'm the Associate Chair of Clinical Occupational Therapy Services for the University of Southern California. In reviewing your report, I noticed that occupational therapy was mentioned in aging. I worked in mental health, though, so my practice was in acute psychiatric facilities and community-based mental health. Occupational therapy providers are out in the community. We're in facilities, we're in people's homes. We just modernized our Practice Act in the state of California. Mental health is mentioned 3 times in our Practice Act, but yet occupational therapists were not mentioned as part of the solution to the workforce shortage of behavioral health. So my question for you is how to include providers across the spectrum. I understand NPs and psychiatrists and the emphasis there, but occupational therapists and others can be a really strong part of the solution. Dr. Cornea, you had mentioned also practicing at the top of your license. That's a challenge that we face with policymakers and with payers, and I think in addition to adding more workforce, removing some of those barriers is a huge part of the solution. So I'd just like to hear more about that. Thank you.
Anybody like to?
Yeah, I can respond real quickly. If you look, especially in the last 2 to 3 years of life, there are 3 factors that really drive both life expectancy, individual patient satisfaction with their circumstance, and costs in a really substantial way. They are clarity in terms of what it is that the patient wants from the healthcare system. They are having a good social network and not being socially isolated. And the third is being able to safely do the things you need to do every day to take care of yourself. That is an occupational therapy issue, no question about it. And I think your comments are very well taken. The idea that we can meet the needs of the senior community and others without addressing issues of the availability and proper financial support or payment for occupational health services would be short-sighted given that. And you?
Well, I would just say, you know, the challenge for me in the report, and it's a great report, I think, and it'll be greater if we actually act on most of the recommendations, is it's still to it's still to sort of top, and I'll just say this, top of the food chain heavy, which was one of my concerns going into the work. And I think in aging, we were able to sort of raise a discussion about the need to sort of clarify, hold up, and improve how we think about home care workers or universal kind of home care worker as a concept or construct to discuss. I think the reality is this is about teams of care, and it is, and I think the thing we need to be willing to take on in this state, beyond just sort of filling the pipelines, is to stop talking about top of license and actually sit down with the interested parties who don't want that change because they think it's bad for their space and try to solve that problem. I mean, from my perspective, there's plenty of work to go around here. And I am, as a physician, I am skeptical of the idea that we can shove one more thing in a primary care provider's office, and that the primary care provider is going to do all this care. This is not, having been a primary care provider, this is not going to happen. So I think one of the things that I will continue to highlight about this report is the need to get serious about sort of the teaming questions, because it's not just occupational therapy, and so I really appreciate the question, but you know, physical therapy, the role of pharmacists. I mean, you could really rethink how we work in teams to improve outcomes. And like I said, I think there's plenty of work for each discipline, but we just need to have a safe space for that discussion.
Yeah, thank you. And I would just add a quick comment, because it'll, following what Dr. Chernof just said about all the different health professions. In the report on page 23, you'll find a series of recommendations about essential changes in the marketplace that we recommended. One of those being practice transformation, i.e. team-based care, and moving towards global capitation. Once you capitate the team or a health system for the services they're supposed to provide, all these turf issues disappear, because now it's about getting the job done in the most cost-effective way. So I think that's a theme that we definitely discussed quite a bit at the commission level. It's one of those cutting room floor things that got cut, but the concept is there are some marketplaces that we need to advocate for to make sure that that happens. So.
Hi, I'm C. Freeman. Thank you. I am the president of Los Angeles County Medical Association. I happen to be a geriatric psychiatrist with training in internal medicine, so I have found today's discussion very, very heartwarming as well as stimulating. I was interested that the commission did not address the particular issue that serves as a barrier for licensure in the state of California, specifically as it relates to acknowledging whether or not you have been treated for mental health services. And so the idea that we can create a pipeline for people who may have had experiences, challenges with mental health, receive treatment, and are functioning, that it actually may serve as a barrier for licensure. So I noticed that. And second issue why I'm here is that I was particularly excited about the GME California entity and wanted to know what your thinking was behind that.
And our idea on that, thank you for your question. Our idea on that was just to have a way to make sure that we coordinate efforts of training, and so we're not reinventing the wheel, and that we're able to identify these pipeline programs, how they articulate to the health professions training programs, and how to maximize the opportunity for young people who say, I want to go into a health profession. You know, when they're in high school and college, they're the pluripotential stem cell. They haven't decided they're going to be a liver or a heart or a brain. So we want to make sure that we have an organized way to do that all the way up to postgraduate training. Thank you.
You know, I don't want to kind of slide over the point that you made about the question in the licensure. I would argue that that's a holdover of the long-standing challenge we have with stigma related to mental health. And so I do think that moving that into the conversation when we talk about top of license, when we talk about the way licensing is done in this state, having that as a legitimate question that we need to address would certainly be appropriate, and I think would fit easily into the context of the recommendations that are presented in the report.
Thank you very much.
I'll briefly add, I think the peer provider recommendations are going to actually force that issue onto the table. Some of the research that we have done on peer provider roles is that those who say want to work in a program that is helping people transition from incarceration to the community, the best served people for that are people themselves who perhaps have had that experience of incarceration, and there are all kinds of barriers to their employment. So I think that that recommendation may be the pathway by which all of these issues get opened up.
Good afternoon. My name is Mariko Khan. I am the Executive Director of Pacific Asian Counseling Services, and as such, we provide mental health services under the Department of Mental Health to a wide range of underserved populations, but particularly APIs. And first of all, I want to commend all of you. I am so impressed with your findings and your recommendations. I really didn't expect them to be so holistic and really understanding behavioral health and medical health. Just as a comment, I wanted to tell Dr. Chernof that in LA County, we have an underserved cultural committee, and we just recently added older adults as one of the underserved. So we moved away from ethnic.
Thank you.
We've added the older adults. My question is a little bit more related specifically to APIs. Perhaps it's covered in your fuller report. But when you talked about doctors, you talked about Southeast Asian doctors, not about API doctors, which are probably well represented in the workforce. And working with an FQHC, one of the things we find is our Asian doctors do not work in the community. They want to be entrepreneurial and work on their own. And I wonder if there's any ideas about how to make them more community-oriented. And the second part of that is the linguistic challenges. My staff speak 8 different API languages plus Spanish. So one of the things we find is we have to hire foreign-born graduates in order to meet language needs. And it's a big expense for nonprofits like us. So I wonder if some consideration can be given down the road to that need to hire foreign-born graduates in order to meet that linguistic need.
Dr. Cornelia, do you want to talk about maybe the Kaiser Medical School and how you're going about it differently?
I can touch on the Kaiser Permanente School of Medicine as one element, but maybe expand on that a bit. Part of what we recognize is we need to understand what are the artifacts of the current candidate selection process that diminishes elements of their life experience, that really predicts that they'll be an excellent physician, the kind of physician in this case, who would see the intrinsic motivation that drives their practice, bringing them back to the communities that they connect with. So understanding that, I think, is critically important, and creating a medical school environment or whatever training environment that you are creating so that it does support them, lets you know that you recognize their unique contribution and their unique background, and gives them supports to be able to continue to pursue any career that might reconnect them with those communities. I also think we need to understand better what both the intrinsic and extrinsic motivators, the financial benefits and also the personal mission benefits that come from practice, and make sure that all of the professionals that we train remain connected to that. I also think that built into these recommendations is a very clear recognition of career ladder opportunities, where individuals who are drawn from those communities and remain connected to those communities as promotoras or other community-based workers see their trajectory towards participation at different levels in the healthcare workforce as remaining connected to those communities and bringing greater and greater benefit to those communities. Maintaining that connection over a longer period of time where people build the skills and add contribution to the healthcare of their communities, I think, is one of the areas that this report can help address.
No, I hate to be the bad guy because as a moderator, my charge is to keep us on time. We did start 5 minutes late, so we'll take 2 more questions. If you can please be brief, and I apologize to those of you who are standing, but if you write your questions in the cards, we will be sure to answer them. Thank you very much.
I will keep it brief. Good afternoon. I'm Talia Puzantian. I'm faculty at Keck Graduate Institute School of Pharmacy, where we're also developing a new school of medicine as well. And I, along with my colleagues, are helping to develop the next few generations of pharmacists, and I was glad to hear your comments about that. I just wanted to add that we have 40,000 licensed pharmacists in our great state, including counties way up into the far reaches of the state. We are accessible, we are trusted, we're knowledgeable, and we have already made lots of inroads in terms of public wellness with immunizations and oral contraception and recognizing people at risk for opioid overdose and providing naloxone. And we, under collaborative practice agreements, are practicing throughout the state in FQHCs, in VAs, in academic centers, in county mental health clinics, county primary care clinics, and we manage chronic disease states, hypertension, anticoagulation, diabetes, and certainly behavioral health as well. As a board-certified psychiatric pharmacist, it's what I do every day at Adventist Glendale. And so I surely hope that there will be room for us to be included in all of the great things that you've outlined here today. So I want to thank you for that.
Esquivel. I'm the Training and Education Director of Visión y Compromiso. That is a national nonprofit organization that support the work of promotores, but more important than that, it's represent the voice of promotores at the national level. And I feel very pleased to hear that one of the recommendations is to scale the work of promotores and community health workers. I'm a promotora. I have more than 20 years of experience in the field. I'm an immigrant. I was born in Ciudad Juarez, Mexico, where I studied psychology. But when I come to United States, I didn't know the language. I couldn't use my profession to work here. And thanks to a promotora program in that years, that I was a part of Planned Parenthood Los Angeles and also Hathaway Family Resource Centers, I received a lot of opportunities and training to serve my community. And I was hearing your recommendation to scale the work, and I'm very happy and very pleased. But I also, working with Visión y Compromiso and working with a lot of community leaders around me, I really want to recommend that when we scale the work of promotores, we do it with them. Because I hear a lot about training and also compensation for the work the promotores do. I start as a volunteer. I start working and getting stipends. Now I have a full-time job as a promotora and director of training. But a lot of my colleges don't have those opportunities. And they also don't have health insurance also. So we're trying to work for the health of the community, but we also being neglected in the services that we are providing. And when I hear certification, I also think, is that with the voice of promotores? Is that something that really will involve us in the conversation? Because I really think that training is an opportunity, receive compensation is an opportunity. But when we talk about certifications, and our organization has an Institute of Promotores, they truly recommend us, don't have a mandatory certification, but they do want to receive the skills and the training to become better servants of their community. But thank you.
Well, and thank you for your question and comment. What we worked on as a commission was to look at recognizing the training programs, community-based and others, that actually distinguish themselves in giving the graduates the skill sets they need to be effective change agents and community health workers in the communities they serve. And we didn't want to do more than that because it would become a barrier to the folks' ability to work. And again, in terms of the compensation, we believe and strongly believe as a commission that we should be conducive to folks having a living wage and upward mobility throughout their careers so that there should be no barriers. So for example, thanks to Dr. America Bracho at Latino Health Access and Maria Lemus at Visión y Compromiso, we've been training promotores to work with the county's whole person care program and health homes program, because county has superior salary and benefits, and it's a chance to make a statement about the quality of work that promotores make. We need to scale that up across the state as well and make sure that that's recognized. But thank you for your comment.
A quick comment actually about the role of pharmacists. For most of my career, I've enjoyed the benefit of really strong, effective, collaborative practice with pharmacists. I have seen the impact that their role can have on the ability to control blood pressure, the ability to control diabetes, and the idea that that is actually one of those workforces of highly trained, very skilled individuals who could have a significantly different role in meeting the health and healthcare needs of the residents of the state. I see that as one of those things that we can pull forward into the problems that we have right now and solve them earlier than we can consider when we talk about the long-term projections for improving training and increasing the training of professionals. So I see that as an early win. Yes, yep.
Global capitation, that way you don't have to worry about, piecemeal work, but thank you for the comments. It's my pleasure now to introduce Dr. Peter Long, President and CEO of the Blue Shield of California Foundation, a great champion for underserved communities. In his past, he's been a executive director or CEO of Indian Health Service clinics, as well as been very supportive of the safety net throughout California. And he's been gracious enough to give us the wrap-up comments. Dr. Long.
Thank you. They told me I had an hour, so hopefully I'll be under that. No, it's a great privilege. I'll just make a couple of remarks. I'm the president and CEO of the Blue Shield of California Foundation, where we're working to make equitable and sustainable solutions to make California the healthiest state with the lowest rates of domestic violence. But 3 points I want to make in closing. I had about 15 pages of notes in seriousness. I hope you all did too. But the 3 points I want to make are, this is a policy window. The Governor Newsom, in his first 30 days, 100 days, has talked and set ambitious goals about which are access to health care for all Californians. He has set a vision of California for all. What we at the Workforce Commission, we as the funders and the workforce commissioners and the staff, this is about how you do it, right? So the governor has set a vision about what he wants to achieve and what he wants California to look like. What the Workforce Commission talks about is how do you actually do that? And I would say Dr. Alexander has been working on this for 30 years. When we first started this as funders 2.5 years ago, we came together, and the first way you know how to do things differently is when you acknowledge you have a problem. So we as funders got together and said, we all are funding workforce. We are all funding different pieces of this elephant, but we're not making a difference. It's not adding up to anything more. So we stepped back and said, how can we as health funders here in California contribute to a different view, to a different outcome, to different results? So this is actually a germination of funders stepping back and being self-reflective of how could we start by acting differently, by pooling our resources, working together, bringing together the brightest minds to actually come up with a different set of solutions. And so I have 4 reasons why I think this is different, because we've had reports on workforce before, but 4 reasons for you I would submit. 1, this is person-centered with a holistic view. So many times we've done parts, right? We've done parts of the workforce, whether it's our brains, our hearts, our legs, our knees, different aspects. This is a person-centered, actually about, people, and then a holistic view around what are all of their needs, emotional, psychological, physical. Second, I would submit that it takes a longitudinal view of health. So often we're episodic in how we do health. Let's get them in the hospital, let's get them out. It is comprehensive and data-driven, as you heard from Dr. Spetz and others. This is informed by data. And it is grounded in the views of thousands of Californians who are both individuals and represent organizations. This is actually a very, very extensive process over 2 years of deep inquiry. 3, we are all working on this together. This is not a couple, the nurses are working on it, or the pharmacists, or the community health workers. Everyone who is interested in the future of the health of our state is welcome. And they have been welcomed to the commission, and I will welcome you to what comes next. And then the 4th, and to me as a foundation person, that is most exciting, I think for all of us who are working in the trenches or in foundations or individual organizations, this is bold, at scale, and sustainable, right? These are not small ideas. Fixing the workforce gap, putting together a $3 billion price tag, and naming what it will take to invest in our future, that is a bold, scalable, and sustainable solution. So to me, yes, this is a report, and we've had other reports before, but those 4 things to me make it fundamentally different, and I think we're going to get a fundamentally different outcome. And then my 3rd point is that's where you come in. This is, I'll quote my former colleague Mark Smith, this is the end of the beginning. So if you didn't like some of you who didn't see what you wanted to see in the report, keep talking, keep working on it, keep activating. What we would ask is what the report offers is an investment in people, a removal of barriers, and a scaffolding to have this conversation, right? That's really what this report offers and what the commission offers. So what I would ask you respectfully, if you're not in the report, you don't see your vision or your cohort, engage around investment, engage around removing barriers, engage within the scaffolding we presented. Challenge it, but engage within this process and to be a part of the solution. There are things planned that we have planned in terms of the next meeting, as Judy said, is in Fresno on April 23rd. Please encourage your colleagues, go yourself. Around primary care and prevention. There will be a budget hearing in the state legislature. There are a number of proposals already in the works. And I can personally assure you that this governor and this administration deeply cares about these issues and is paying very close attention to what's happening in this report. So I think there will be, we should see some action, and at the very least we will see a very engaged administration willing to work forward because they know they've set the bold goals and that this is actually how they're going to get there. So in closing, I just want to thank the panel. I want to thank the commissioners, the staff, my fellow funders, and most importantly, thank all of you for coming. We will change the world together. So thank you and good afternoon.